There's an absolute smorgasbord of transcatheter technologies available right now. I think if you look at it, there's some that operate on different levels, and that's probably the best to look at. So you have on one side, you have MitraClip for the tricuspid, which has over 100 cases that have been done worldwide. You also have the annuloplasty technologies, and some of these include those such as Trialign, as well as also Cardioband, which is moving into the tricuspid position. Both of these work on bringing the annulus together. In addition, you also have TriCinch, which is another technology that involves a stent placed into the IVC. Separate from all this, you have other technologies such as cable technologies, which includes implanting a valve into the IVC as well as into the SVC or just into the IVC alone. There's also other valves that are moving into that, but that's just the repair technologies for now. I think the big thing to look at for clinical practice is you really have to understand what the appropriate patients are, just exactly like you said. If you have patients that are surgical candidates, I think the big thing that surgeons will say is surgery is still an option. However, from STS database and other things, we know that isolated tricuspid regurgitation has a mortality of about 10%. And why is that? Some of it may be these patients are coming too late. Some of it may just be that these patients are very sick. But either way, there's a sizable proportion of these patients out there. So there still is a market for all of this, part one. When you come into the percutaneous market, I think tricuspid regurgitation presents in a variety of ways. Some of that happens with significant edema. Some of that happens with liver and kidney failure, for example. A lot of these things happen in the context of mitral regurgitation as well. So you have patients that are coming with mitral as well as tricuspid. And we know that patients that have the mitral treated but don't have the tricuspid treated also don't do well. So I think there's two different ways in which those patients come. Symptomatically, you'll have patients with significant edema as well as liver and kidney failure, like I mentioned. The key thing on the edema, that it's not responsive or it's refractory to increasing diuretic use. And some of that may be due to gut issues, but I think the big thing is that when you have that constellation there, these patients are probably great candidates. I've only talked about anatomy. I've talked about clinical selection, and I've talked a little bit about in the context of other valvular disease, for example, and patients that are technically challenging candidates based on reoperative status, frailty, et cetera, et cetera. The real big thing that's out there is trying to figure out for what anatomy is which repair technology going to be useful. And you have to look at multiple factors. The same way on the mitral side, we're looking at this as a complex. On the tricuspid side, we have to understand this as a complex as well. You have the anterior leaflet, you have the septal leaflet, you have the posterior leaflet. There's so much variety within this. For example, there's papers showing that the posterior leaflet can have multiple scallops, for example. That's one aspect. On the annulus behind it, you have to really understand how much annulus is there and whether the annulus can handle multiple interventions or not. For example, patients that have prior steroid use, this could be an issue. You also have to understand how much the RV is working, what the pulmonary artery pressures are, and also the papillary muscles, as well as all that whole constellation of different anatomical features. So to summarize, because I've gone kind of all over the place, I think the big thing is you really have to understand which patients are high surgical risk, number one. Number two, you have to understand which patients are symptomatic and what that means in terms of symptoms. Number three, you have to really understand the anatomic criteria, and that comes from absolutely excellent pre-procedural imaging, both with transesophageal echocardiogram, CT, and sometimes also with ICE as well.